Hello friends, today our topic of discussion is on ischemic stroke. We will discuss elaborately on ischemic stroke. Then coming to pathophysiology of ischemic stroke. The magnitude the magnitude of flow reduction is the function of collateral blood. So the ischemic stroke, the clinical features depends upon the magnitude of flow reduction from the collateral vessels. If the main vessel is blocked, the collaterals will supply the ischemic area. So, how much the collateral blood flow is decreased, is it causes the ischemic size. So, what is the reduction in blood flow? If blood flow decreases less than 20 ml per 100 gram per minute, it causes ischemia. Unless ischemia, it lasts for hours or days together. If blood less than 16 to 18 ml per 100 gram per meter, for it causes infarction within 1 hour. If the blood becomes zero for 4 to 10 minutes, then the brain tissue will die. So this is the pathophysiology and how much reduction causes how much damage. Then main concept is ischemic penumbra. What is penumbra? Penumbra is ischemia but reversibly dysfunctional tissue. Means uh, in the diagram you can see the black thickened black is infected area, so we can't do anything for that, but surrounding that area is ischemic penumbra. So this ischemic penumbra can be imaged by perfusion scans of CT, MRI perfusion or CT perfusion, and our goal of reperfusion therapy is to save this ischemic penumbra, because the central part is already infected, so we can't do anything. So ischemic penumbra saving is our goal. Okay, then this infarction will occur by two pathways. One is necrotic pathway, other one is apoptosis. What is necrosis? Because of lack of ATP, the cell membrane can't maintain its cell membrane structure. So because of ATP, energy failure or lack of ATP, there is necrosis of the cell membrane. Then the ischemia produce necrosis by following starvation of neurons of glucose and oxygen. Second, without ATP, the intracellular calcium will rise. Then extracellular glutamate will rise. Then free radicals are produced from degradation of this lipid membranes and dysfunction of mitochondria. So by these mechanisms, the ischemic necrosis will happen. Then fever and hyperglycemia will worsen the brain injury. So fever and hyperglycemia. Then coming to treatment. Before treatment, we have to differentiate it from ischemic stroke or hemorrhagic stroke. Okay, for any treatment, first ABC means airway, breathing, circulation. So we have to differentiate from hemorrhagic and ischemic stroke. We can do CT. Without CT, how can you differentiate? How to try to differentiate hemorrhagic and ischemic stroke? So in hemorrhagic stroke, at presentation, patient will be more depressed level of consciousness. The consciousness level of patient will be more depressed in hemorrhagic stroke compared to ischemic stroke. Then BP at presentation will be higher in hemorrhagic stroke, and worsening of symptoms after onset of event. But in ischemic stroke, at presentation there will be maximum deficit, or the deficit will remit, means it will decrease. But we can straight away differentiate it by CT brain. But if not available, we can clinically try to differentiate. And another important concept is time of stroke concept, because for treatment for thrombolysis we have to know that time of stroke onset. Okay, first, time at patient symptoms were witnessed to begin. If you see the patient, the at what time the patient symptoms witnessed. Second, at the time at the patient last seen normal. And third is time at the patient went to bed if he awakens with stroke, means time at patient's symptoms were witnessed to begin, time at last seen normal, and went to bed. So by this we can thrombolyze or not thrombolyze within the time period. We can thrombolyze. If greater than window period, we can't thrombolyze. So we will discuss later. Since collateral blood flow is important for ischemic brain, it is depend upon blood pressure. So we won't decrease the blood pressure, but we will decrease the blood pressure in the following situations. And one, if blood pressure is greater than 220 by 120 millimeters of Hg, then malignant hypertension, then concomitant myocardial ischemia, then BP greater than 185 by 110 if you are planning for thrombolysis. So these are the conditions. If concomitant MI is present, we can decrease BP by using beta blockers like esmolol. It will decrease both heart rate and blood pressure. Then, as I already discussed, serum glucose, hyperglycemia, and fever should be treated. The serum glucose should be maintained between 180 milligrams to 60 milligrams, and fever should be treated with antipyretics. Then coming to cerebral edema, it is a complication of ischemic stroke. It is seen in 5 to 10% of the patients. The cerebral edema peaks between second to third day, but the mass effect will remain for 10 days. So if there is significant edema, we should treat by water restriction and IV mannitol. But we should avoid hypotension because it may worsen the infarct. Then hemicraniotomy. Hemicraniotomy means removing the cranium so that it will decrease the cerebral edema. In European trial, it showed it reduced the mortality by 50%. Greater than 60 years also there is benefit, but it is not as benefit as younger patient. Then note about cerebellar infarct, because cerebral infarct will be easily missed because it presents as a vertigo and vomiting, nausea, vertigo, like labyrinthitis. But the physician, the following symptoms should, like headache, neck stiffness, or head pain or neck pain, and dysmetria, uh, should make the physician to look for the cerebellar infarct. It is mostly due to vertebral dissection. Vertebral artery, V4 part of vertebral artery, it is a part of pica, posterior inferior cerebral artery. And the thing is, small cerebellar infarct also dangerous because it increases the ICP, intracranial pressure, by obstructing the CSF outflow and directly compressing the brainstem. So because of compression of brainstem, it causes coma, respiratory arrest, and which requires emergency decompression because cerebellum, coma, respiratory arrest, emergency decompression, mostly from the suboccipital or suboccipital decompression is preferred. Then coming to the main thing, IV thrombolysis. The main study for this is Ninda's RTPA stroke study. The efficiency is confirmed within 3 hours and can be extended up to 4.5 hours according to European study ECAS 3. So up to 4.5 hours will be used in for thrombolysis, used in Europe and Canada, but US until 3 hours only they will use, possibly until 6 hours. The dose is 0.9 milligram per kg body weight, maximum up to 90 milligrams, and 0.6 mg per kg body weight in Japan and other Asian patients because they have more chances of hemorrhage. Then coming to endovascular revascularization. Because of occlusion of large arteries like internal carotid artery, MCA, basilar artery, because of large artery there will be a large clot. That large clot failed to open with IV, that plasminogen activators, reverse transcriptase plasminogen activators. So we will inject endovascular, we will inject directly this into the vessel, endovascular revascularization. The study is proactive paralysis in acute cerebral thromboembolism. In this, we will inject, in this trial they injected urokinase in MCA, middle cerebral artery, within 6 hours of presentation. But this is not approved in US and by FDA. Then endovascular revascularization, this is. Then endovascular thrombectomy, we will remove the thrombus from the vessel, endovascular thrombectomy. Then coming to anti-thrombotic treatment. First, platelet inhibitors. There are many platelet inhibitors can be used in secondary prevention after the acute event, but for the acute event, aspirin is only agent proven to be effective in acute treatment of acute ischemic stroke. Clopidogrel, dipyridamole, and all others can be used from in the secondary prevention. According to IST, International Stroke Trial, and CAST, Chinese Stroke Trial. In International Stroke Trial, they used 300 milligrams per day. Chinese 160 milligrams per day of aspirin. This trial proved beneficial effects of aspirin. Then anticoagulation. Anticoagulation is very risky, so it is not recommended because it increases the risk of systemic and brain hemorrhages. In atherothrombotic cerebral ischemia and stroke associated with dissection, arterial dissection, anticoagulation should not be given. Only treatment is aspirin. For both cases, only treatment is aspirin. For dural sinus thrombosis, anticoagulation should not be given. Only aspirin should be given. Then for dural sinus thrombosis, anticoagulation should be given. So for atherothrombotic cerebral ischemia and stroke associated with arterial dissection, we should not give anticoagulation. But dural sinus thrombosis, we should give anticoagulation, because this anticoagulation will halt the progression of sinus thrombosis. So we have to give anticoagulation in dural sinus thrombosis. Then coming to neuroprotection. Neuroprotection means, the principle of neuroprotection is to prolong the brain tolerance for ischemia. If brain tolerance to ischemia is prolonged, then brain will survive more for the ischemic environment. So main thing of neuroprotection is, principle is prolong brain tolerance to ischemia. So there are many things tried. One of them is drugs that block excitatory amino acids, because excitatory amino acids will only cause the damage of brain tissue. So drugs that block excitatory amino acids is tried. In animals, it protected neuronal and glial cells, but in humans, the beneficial effect of drugs that block excitatory amino acids not yet proved not yet proved its beneficial role. Then coming to hypothermia. Hypothermia is useful in cardiac arrest, but in acute ischemic stroke in animals, it proved its neuroprotective role, but in humans, it's not at animals protective, but in humans not adequately studied. And it increase the risk of pneumonia in humans, which is a adverse impact of stroke outcome. So hypothermia also not adequately studied. Then stroke center and rehabilitation. In the stroke center, they have to counsel the patient about their illness and complication of immobility, like deep vein thrombosis, etc. Complication of immobility, deep vein thrombosis, for which they should give an heparin or stockings to prevent DVT. And another thing is constrained movement therapy. In this, the normal limb is the normal limb is stopped from moving, so he is forced to use his paralyzed limbs. This therapy improved hemiparesis even after years. Thank you.